Well, good evening, good afternoon. Thank you all for coming. Really, thank you very much for coming. My name is Trevor Perry Giles. I'm the Director of Academic and Professional Affairs at the National Communication Association. And one of the things we try and do at NCA is advance the discipline of communication by talking about the various domains of human life and human activity and behavior where communication can play a pivotal role in advancing the work and the endeavors that good people across a variety of sectors, from health to politics to organizational life, etc., are attempting to pursue. And I think it's in that spirit that we've sponsored this year a couple of programs about health communication and health disparities in disadvantaged or underrepresented communities. And I think that's what we're trying to hope to achieve tonight with our discussion of communication, culture, and health, as those exist here in the unique context that is New Mexico. I will admit I'm a native of New Mexico. I was born and raised here and am an alumnus of the University of New Mexico. And so it's great to be back home and to talk about these very important issues here at the university. I guess without further ado, I will introduce and thank my colleague, Lakeisha Anderson. Dr. Lakeisha Anderson is she'll laugh when I say this, world-renowned expert in health communication. She has a Ph.D. from George Mason University, and she's going to moderate our discussion this evening. Before she gets started, though, again, I want to thank you all for coming so much. I hope that you'll engage with this conversation as it unfolds. Feel free to join the conversation on Twitter at #NCA Conversations, and we'll certainly try and spearhead any questions that you might contribute to Twitter up to the podium for interaction and discussion. And again, thanks so much for coming. Lakeisha.
All right. Again, thank you guys for coming. I really appreciate that you're all here with us. Our goal with this program is to engage in a discussion about the impact that culture has on health and the unique barriers to health faced by residents of this very diverse state. We'll explore ways that communication impacts health by discussing topics like health literacy, provider, patient, and community health relationships, and communication about specific diseases and conditions that disproportionately affect New Mexico and its people. Tonight we're joined by scholars and community practitioners who represent the university and community. I'm going to introduce them to you now in no particular order. Although nope, okay. I was going to say they may be sitting in that order, but they're not. Dr. Lorenda Belone, sitting right here, is an assistant professor in the health education program in the University of New Mexico's College of Education and the co-founder of the Center for Participatory Research. Theresa Clay is the director of the Health Promotion and Disease Prevention Program for the Indian Health Services Albuquerque area office. You could raise your hand, just let people know who you are. Okay. Dr. Tamar Ginossar is an associate professor in the Department of Communication and Journalism here at the University of New Mexico. Jaron Key is a third-year medical student here at the University of New Mexico School of Medicine. Dr. Johnny Lewis is the director for the Community Environmental Health Program and Center for Native Environmental Health Equity Research. And Nathania Sosi is the associate director for the Center for Native American Health here at the University of New Mexico Health Sciences Center. These are very abbreviated bios for each of these individuals, which you can find outlined here in your program. A very accomplished panel that we have here with us tonight. So as we discuss the ways culture impacts healthcare here in Albuquerque and greater New Mexico, I know that you'll have questions and comments, and we look forward to hearing from them. Once the panelists' discussion is over, there's going to be a Q&A session, and we look forward to hearing from you at that time. So if you can keep all of your questions until that session, that would be great. Again, thank you all for coming, and we're going to get started. Okay, so the first question that I have for the panel asks you to focus on the populations that are specific to New Mexico and how that impacts health barriers. So what are the most important barriers to health care in New Mexico, and can you elaborate on the barriers to health that the many different populations may face? For instance, rural versus urban populations, and Native American and Latino communities, which comprise large populations in the state.
I'll go ahead and go first. As we all know, there's many barriers and many challenges in our rural communities, and a lot of people say it's access to care, and it's really access to quality care, specialty care in our rural areas, because a lot of people have to travel so far to get to clinics or hospitals, and that's one of the barriers, the cost to it. They have to take time off work, they have to get money for gas, they have to get family to watch their kids. So there's many costs that come into play with that. So a lot of it is access.
And I think just to add to that, in addition to those barriers to access, there's also a tremendous lack of infrastructure in a lot of the communities. And what that ends up doing with respect to healthcare is really increasing that burden because of the need, an example of people who are hauling drinking water, which is not at all uncommon here. And especially on Navajo communities, there's about 35% of people that don't have access to regulated water systems. And so just the amount of time it takes every day to get water in and to get wood in to build fires, and then you add having to travel 400 or 500 miles to get health care, that becomes a really significant burden. And I think that's an extra piece that adds to all of those other issues as well.
I think what I'd like to add, and my perspective is one as a researcher. I'm a researcher, have conducted research with numerous tribal communities here in New Mexico. I'm not on the delivery or healthcare delivery end. My focus is on a number of different things, but in going into these communities, and I'm Navajo, so I go into a lot of different communities other than my own, so I get to learn a lot about the other tribal communities. But my experience has been, particularly for the rural communities, when I do my research, I travel two hours one way. In one community, I travel 3 hours one way, and fortunately I go 1 hour one way. So just to get out to the communities can be an issue. And once I'm out there, I'm also a community-based researcher, so I want to engage the community in the research process. So I knock on a lot of doors just to learn about the community. And in one of the communities, the 3 hour away community, I was really surprised because I want to engage the community. I want knowledge and expertise of those who are already in the community. So I'll knock on behavioral health specialists, I'll knock on the social services specialists, I'll knock on the clinic, the hospitals, I'll knock on a lot of different doors. And sometimes there are no doors, those doors aren't available. There is no one in that position. Sometimes there is the door, but again, someone has left the community because it's a specialized area and there is not that person there. So they may be in existence with regards to a place to go to, but the personnel is not there. So that's been my experience. For some of the tribes, they are able, depending again on the size and their focus, they're also able to 638, I don't know if you want to go into 638 discussion, meaning they're able to seek control over their own health programs. Some communities are able to do that. And if they're able to do that, they're able to actively recruit those types of positions into the community. For those who aren't able to seek and actively recruit 638, their programs and run their own programs, oftentimes they rely on the Indian Health Services to fill it. And those are the doors that I usually find that aren't filled, or there's a rotation occurring and there's seasonal changes. And if you're working for the Indian Health Services, sometimes you're a public health service officer and you may be commissioned there for a certain amount of time, then you go to the next location. So those are just touching on this issue a bit. Those have been my experience when I try and knock on doors in these communities that aren't my own and trying to find out who is there, because I really want to access their knowledge and expertise.
Okay. All right, thanks, Jaren. I think I also just want to add too that in addition to what's already been highlighted in the rural and reservation communities, that's not to say that the urban Native Americans also don't face the same issues. I think the latest statistics show that there are about 60% of Native Americans now live off the reservation and are living in cities like Albuquerque, Phoenix, and Denver because of proximity to jobs and education and so forth. I think the transportation barriers are still present here within urban communities, especially because of things like public transportation and access to regional transportation. Those also pose barriers, not just for Native communities here in the urban area, but also Latino and other low-income community members as well. I think also, in addition to some of the infrastructure that was highlighted already, including water access and transportation access, there's, those are really serious public health issues because it relates back to the infrastructure that is possibly and probably very likely very dated. So we're talking about water lines that have maybe been set in place back in the 1960s and possibly never been updated ever since. In my home community, I'm like Lorenda, I'm Navajo. I live in a really small part, a very rural part of the reservation in Arizona. And the water pipes and the water lines have not been upgraded since they were first installed back in the 80s, I think it was. And so the infrastructure issues are definitely present. I think that our tribes do a lot for their communities, and I think they do the best with the resources that they have. I also think they do a really good job of responding to those emergencies when they're needed. And so I think it's the balancing of those and the timing of those that is really key.
I think in addition to everything that everyone has said, there's also a fundamental lack of understanding regarding cultural competency. Excuse me, I'm a little sick. Not only from, I think, a provider standpoint, but when entering the system, most people don't know how to navigate that system because it's very unknown to them. But as being a provider, unfortunately, or whether it be unfortunately or not, but being in a unique position to be, one, Native American, two, growing up in a very traditional environment and being able to speak Navajo very fluently, I was sent back home during my OB-GYN clerkship. And it was a very interesting experience, to say the least. To see 80-year-old, 90-year-old grandmothers who I view as someone I would not be having these conversations with, complaining of UTI complaints, like suprapubic pain, dysuria. And it was hard to have these conversations, but at the end of the day, giving them that openness to have that conversation was really important. But it was also my lack of understanding that while growing up, I was not allowed to learn anything related to female anatomy, female complaints. And it was that understanding, and being in this position, I didn't know how to have that conversation. I didn't have that language ability to speak to them. So for instance, there was this 90-year-old grandmother who came complaining of UTI symptoms. And in our culture, if you were to literally translate the term for UTI, it's called the bug you can't see. And so I went home to my 90-year-old grandmother, who only speaks Navajo, and I asked her, what does this mean? And she described to me the classic symptoms of UTI, like suprapubic pain, dysuria. And so it's interesting the little nuances you come across as being a provider and being a Native provider. In addition, I think there's also a language barrier. Here in the state, we have not only 19 Pueblos who not only speak Keres, Tiwa, Tewa, Towa, and then those dialects within themselves, but we also have the Spanish-speaking population and a Vietnamese-speaking population. And you actually come across times when sometimes the interpreters aren't available and you have to sit there and wait, and it backs up everything else. And it's just an interesting system, I think, to be practicing medicine here in New Mexico.
I actually took the other day a picture of the parking next to a university hospital, and they actually translated patient parking only, you will be towed, to 5 languages. So I thought, okay, I took a picture of that, and I thought, well, if we also translated more of the signs in the hospital other than the parking, that would help a lot of people. If we had readily available translator and interpreters, that would also be, so I think what we're talking here is definitely very limited resources that we have, and also some decisions at different levels, including the political level, that prevent us from being able really to meet the needs of communities in New Mexico, with definitely rural population, and Native American population and other minority population are definitely even more marginalized.
I just want to add something that, about the language barriers, and Darren spoke to this a little bit. I too am fluent in Navajo. It's my first language as well. It's a funny thing about translating things into Navajo when you're a medical provider, because technically it's the English alphabet that you're using when you translate into Navajo. So there's kind of an underlying assumption that the written language is different. Navajo is an oral language. We're an oral culture. So the conversation and the way that we communicate is very much story-driven. It's very much kinship-based. And to translate that into English for printing, for example, on signage is kind of an unusual, and that's a new development only within the past 10 years. I can't say that my grandparents who only spoke Navajo could go into a hospital and read something that was written in Navajo on the sign, because it's still the English language. You have to know English to read and write in Navajo. So I think there's a little bit of an irony to that, and I think that speaks to what Darren is saying, and also the real value of having traditional native speaking providers. And it really helps to get at those nuanced ideas that are only translatable in our own cultures. And I think it helps to have that background, and also to have access to those resources as well.
Right, and I think Jared also spoke to the dialects. So my research involves Navajo communities, Pueblo, and Apache. And I recall in one of my studies, the Navajo community said, we were administering a survey, an instrument, and they said, we want this translated as well. And so I took a year to get this done, this 200 plus question survey. And after a year, they said, okay, and they worked with me on it, and it took a year. And they said, okay, they were not part of if you know Navajo, the Navajo reservation, there's a larger Navajo, and then there are satellites that aren't readily connected. So this community I'm working with is a satellite. And they said, we want a linguist from Big Navajo, that's how they would refer to the larger reservation, to look at what we produced and check our work. So we wait, send it off, and I'm the researcher. I need to go through all the process to get this approved, and I'm waiting. I get the response back, share with the community, and the community says, we don't like their comments. We don't like, again, just the dialectical changes of how you would say something. They end up just scrapping that linguist's work, and that was another 6 months of us waiting to finalize. So again, those can be, it's the same language, but differences depending where you're located. So those are just some of the examples of some of the challenges. So just to translate something doesn't mean it may be acceptable or it's appropriate.
One last thing, I think something that we often don't consider in medicine is our measurements. And we were just I'm on psychiatry right now, and the way we assess cognition and memory and attention is having patients count, or having patients subtract serial sevens from 100, or having them repeat or recite for us the months forward and then backward. I don't think my 95-year-old grandmother would be able to do any of those because she's never stepped a foot in any sort of Western education. And it's important to have that understanding when you go and approach these patients. And even pain is something that's really interesting back home. And we have a number of people who even are like high-risk pregnancies who come to the hospital here and are deemed high risk, and they spend the rest of their pregnancy here. But when they're delivered or when they're in labor, their pain scales are very minimal. They rate what a normal average person would be like at a 7 or 8, and they would get an epidural. to be like a 1 or a 2 and a 3. These are lived experiences of pain, and the perception of pain is something interesting as well.
I just wanted to bring up something else too. I know we're talking about challenges and barriers, but my grandparents would also want to make sure that we bring up looking at what we do have in our communities, like our language, our culture, and all the perils that we have, the assets in the community, and not just the challenges and barriers, and really focus on our assets as well. So just wanted to point that out. And I'm also Navajo as well.
And I think what Jaren pointed out about instruments and assessments becomes really important. We do a lot of birth cohort studies and look at development, and part of a national set of cohorts that are doing that. And what we rapidly learn is that there are no developmental instruments that have actually been normed on Native American populations. And when we start doing these, we realize that the ones that we've selected are being used nationally by virtually every federal program to label kids as to whether they have developmental delays or not, whether they qualify for early intervention services, and to a lot of degrees that diagnosis is going to follow those kids into the future. And it's either going to potentially mislabel them as delayed when they weren't, or it's going to label them as doing just fine when relative to their culture they may not be doing fine at all. And it's all of those little things that people don't pay attention to, and you assume, well, we had a relative representation. We had 1% Native Americans in our sample to make these standards, and it's not relevant. And that kind of extends through all of the data sets that we have. There are very low participation rates in research in general, and therefore you come back with an intervention or a clinical treatment, and you really have no idea what that is going to do in the culture that you're working with. And I think that's a huge barrier for everybody.
Right. And I think when you get to research, the norm would be for you to pull an instrument that's been validated, right? But in working with the communities here in New Mexico, if they don't understand the instrument and it doesn't make sense to them, how do you interpret your data? So you've got to decide what you're going to do. And for the most part, again, using a community-based approach, working with teams out in the communities, we've also looked at the instruments themselves. For example, the Navajo community I worked with, we had a Likert scale. Who knows a Likert scale? So you respond to a question and you decide on a 5-7 point scale. I know a little, I know a lot, or, there's a scale. And their response to us was, I could not pick one of these answers. I either know it or I don't know it. You can't, there was no option between, and that changes how you would then analyze, and it changes the validity of the scale that you're administering. And so for myself as a Native researcher, I've scrapped my instruments and said, okay, let's develop something that works for you, and this is our baseline. Otherwise, interpretation makes no sense once you've done the analysis. And it's having to decide to just step back and take that time to be able to do that. So I've had to do that on a number of occasions.
Yeah. I think also as a researcher, we have an opportunity too to add, to use mixed methods. Like we supplement our quantitative data with a lot of stories. And that is an indigenous approach to tell stories, to learn from examples and from people's experience. So I think using mixed methods is also another strategy, in addition to engaging community in the design of the research process as well. I also wanted to just add one more thing too. I think one of the assumptions, and maybe it's more of a barrier for me as a Native person, is that one of the assumptions is that all Native people have the same level of acculturation. And that's just not true. You know, as Lorenda mentioned, culture is not a black and white issue. It's not like I know my culture versus I don't know my culture. There's actually a lot of different levels of cultural knowledge. And some of us are more enculturated than others, and some of us are, you know, don't have the luxury of having that cultural knowledge with us. And so being open to that level of difference in the community, I think, is also really essential and can help us as providers and researchers and educators to really focus on the communities that we're serving.
This kind of leads me to my second question, the things that you guys have been talking about. Obviously, New Mexico is a state that represents a number of cultures, but how does culture impact the access to health issues that you've been talking about? Specifically, can you talk about this in regards to how culture impacts demographic and psychographic factors like gender, occupation, income, literacy, which you've talked a little bit about, family caretaking, attitudes and beliefs about medicine and healthcare. And I've been told that perhaps we could speak up a little bit. Anybody that wants to talk. There's a number of things I threw out at you, so. Yeah.
I can speak a little bit about the gender issues. You know, as a female researcher, one of the projects that I've been working on with the off-reservation American Indian community was this idea of the differences between men and women, and even among Native women as well, Native communities as well. I think I make a lot of assumptions about what I think Native women and men, how they might be similar or how they might be different. And I think the research experience that I've been through really shows me that that's very nuanced through different cultures and different communities. We did a research project, or I helped with a research project many years ago, where we focused just on Navajo women. And it was a mental health study, and we focused just on that group because we thought of them as mothers, caregivers, caretakers, and so forth of the family. And one of the things that we learned from that process was that we learned we were leaving out a huge part of the family, which was the men. And it turned out that the men had a completely different set of health beliefs and health attitudes and the way they wanted to receive care for this particular issue. And I think it's important to remind ourselves of those differences too. And that's just like one way that gender plays into role. I know others will have very good examples as well.
I think to build upon that, one of my early research experiences, I was a graduate student, was being Navajo, being raised matriarchally, and conducting research with Pueblo communities. Some are patriarchal, and having to learn that difference and having to struggle with that issue. We talked a little bit about cultural competency. So going into a community, not imposing my norms, my judgments, my understanding, cultural understandings. So the example I give is, as a graduate student, conducting an in-depth interview with 2 tribal leaders who were men in a patriarchal community, and listening to the responses to my questions, them clearly stating the roles of women in their community, and with their voice of that's not going to change, you know, and I'm matriarchal and I'm sitting there and I'm listening and I'm like, so again, being a researcher is being reflexive, really just looking at your action and not judging their comments. I had to really be reflexive and think about that, and had to understand that's not my community, and I have to respect their words and thankful for what they did share. So that we can address other issues, so that I have their lens and I understand their worldviews. Otherwise, I'm imposing my worldviews and my understandings, and if I'm introducing a prevention program or an intervention, it's not going to work. And I've learned that early on. It was a hard lesson, and I'm really thankful for it.
I think also, just from a medical standpoint, there has been multiple papers done on this very question, and I think we could have a seminar just on this topic alone. But I think to make the biggest blanket statement is that marginalized people, whether they identify as LGBTQ, whether they belong to some minority group, they're going to have different barriers that they have to overcome, and that'll definitely determine the quality of care they receive, how they receive it, and where they receive it. And I think that's the biggest takeaway point there. Something to also consider, and from my own upbringing, is that my grandparents are very traditional. All Navajo speaking. I grew up participating in ceremonies, and there was this one instance a few years ago. My grandfather suffered a stroke, or was beginning to suffer a stroke. Classic symptoms, and refused to go to the hospital. He wanted to see one of our medicine men, and we knew that the time was ticking to get the medication that would reverse, or hopefully reverse, the clot. And we pleaded and pleaded with him, no, you need to go to a medical facility to receive care. And we had to come to a compromise that, yes, you go to the hospital, they'll give you the medication, then afterward, after you leave, you'll go to see your medicine man or medicine woman. And I think that that's a common compromise that happens back home. I'm going to go to the hospital. I'm going to see what the Western thought is. Then I'm going to go home and see my diagnostician, tell me what is going on, and then I'll go find which medicine person to see. And most people back home, I mean, I don't mean to make another generalized statement, but a majority of the people back home that's what they do. They go get their medication from the hospital, and then they go and see their diagnostician, and they ask what's going on. They go see their medicine person, whoever was trained in that, and then they receive herbs, they receive prayer, and that's how things are done back home. And I think that that's a reality that not a lot of people know about, and it's something that's important.
Yeah, I agree with Jaron. It is true that it is really important that our communities have access to a traditional healer, and it should be a part of our Western healing as well, with a traditional medicine person as an option to see that. And I know of a lady who had breast cancer, and she worked with her physician, her Western medical doctor, and her primary or her medicine man back home. And they worked together on the herbs and the pills to make sure that they weren't compromising each other. And so that was a great story, and she actually put a digital story together to explain that to the community. And she's doing well. She's been recovered, or she's in remission for 5 years, so she's doing great.
But I think the issue of trust and the fact that that is so often not appreciated, especially by people representing federal government. And I mentioned earlier about the lack of data that we have to understand even how particular assessments or how effective particular treatments or assessments might be in specific cultures, and that we lack those data. And part of the reason we lack those data is that incredible distrust of being participants in research in general and being participants in research that's funded by the federal government, and what's going to happen to my data, and if these data are shared, how are they going to be used, and what control do we retain over the use of those data. I think what's been fascinating to watch over the last little while, we just recently had a conference on data sharing and genetics from a tribal perspective. And we had a lot of people from NIH there, and there were some people in this room who were participants as well. And one of the really fascinating things for me was to see how the perspectives of the traditional healers and the spiritual leaders is starting to look at ways to integrate in some way with the whole Western research initiative in order to bring integrate some different approaches, not as an alternative, but really as something that might be blended together. And that's been the case on Navajo in a lot of the hospitals. I know IHS has medicine men who are full staff members and they're at any point in time. They've done things to try and create birthing rooms that are consistent with tradition. And to have those kinds of approaches start to be recognized as they're not only an alternative, but they're a really critical piece of healing, and that by working together, if everybody can learn from each other, that we can end up with a much richer treatment.
Yeah, following on what all of you said, in my experience, culture is almost never a barrier. So when people say, oh, culture is a barrier to help seeking and health setting, it's really what they mean, if you look into it more deeply, is that the healthcare setting is not inappropriate. There is a mismatch between the culture, or there is something else completely going on that is blocking people from having access to care, only to later come back and say, oh, this community has a culture as a barrier. It was really rarely like that. So for example, if you think about behavioral health that some people mention here, an ongoing issue in all communities is stigma in terms of help seeking. However, those of you rural, even more extremely so, but even urban, if you try to access any kind of behavioral health care in New Mexico, either at early childhood development or later, it is extremely difficult to not possible, even for people with insurance, for example. So we're really, what we're seeing when people say our cultural barrier, we're really probably seeing something else. We're seeing that the system is designed in a way to not meet communities' health. So for example, one of my studies looked into a clinical trial, cancer clinical trial, and cancer clinical trial overall does not increase longevity by very much. So if you're on a clinical trial in cancer, chances are it's not going to contribute a lot to your longevity, maybe 3 months, maybe 30 days. But some clinical trials are actually extremely effective. So there is a benefit and you get better care overall because you're monitored. So a lot of time being on clinical trial is the right thing to do for a patient. And when I interview physicians, they were all very, very careful, especially if they were majority. They were all very, very careful to say that they treat all their patients the same. They offer clinical trial to everyone who is eligible, etc. But if they were going to say that there are cultural barriers, they said that Native American they would have a somewhat less agreement to clinical trial. But if you look overall, among patients who are Native American or who do attend the cancer center, they're actually overrepresented in clinical trial. So when you are really providing access to people and really meeting their needs in a culturally appropriate way, it's very rare that you find that any culture or any cultural beliefs are a barrier to care. It is just that you have to adapt the care to what people need.
Can you guys talk a little bit more about stigma? You just mentioned stigma. So can you talk a little bit more about that? Mm-hmm. Well, anybody.
Okay. So for me, okay, so stigma is very cultural, right? You may have somewhat different stigmas depending. If we're talking about health, there are definitely certain health beliefs that stigma would prevent you from seeking care or prevention. We focus a lot on healthcare here today, but even if you just think about health promotion or health well-being, I'll talk about one stigma that really prevent people from taking care of themselves, and is happening in many communities, and that's HIV prevention and care. So the stigma there are on multiple levels. And like other issues that we talked about before, rural communities exhibited more stigma about it. So things that are relatively easy to do in Albuquerque, like HIV testing as part of gay pride or anywhere, really are a lot harder to do in rural community. Another example is HPV vaccination. My colleague and I, she's a pediatrician, and we're trying to see if we can look into school-based health centers as places where HPV vaccination will be distributed. And we just heard from physicians that are active in vaccination that in different, and they mentioned different rural communities, some of them are half an hour away from here, that they were basically not allowed to even give this vaccination. Even Albuquerque Public School System, we're willing to work with that as long as we talk about vaccination in general, not just HPV. So that is stigma related to the fact that HPV is a sexually transmitted virus. So that's a few examples where virus can prevent communities from seeking help.
I just wanted to say too, there's a lot of mistrust going on in our communities with our healthcare systems and hospitals, just based on prior history from a family that may have gone to the dentist and got the wrong tooth pulled out, and that carries down from generation to generation. And it's really hard to overcome those stories that you hear from your family. So, I think the healthcare system is getting better, but we have a long way to go to really build that trust and make sure people want to go to the clinic and not just to get seen for like maybe a heart attack or when they faint, but to go in to see a team and do really focus on primary prevention, where we're working with people before they get sick.
Right.
And so really pushing that in the communities and there's a lot of good things going on in communities, a lot of Just Move It walks. We have a running medicine group here in town. We have the Pueblo Crossroads that are going on within our communities. So just those positive events that are happening in the community, and really trying to get people to stay well and not end up in the hospital because they don't trust the healthcare system.
Right, and sometimes they have current good reason, not, I mean, no offense, but so for example, our hospitals, believe it or not, don't do a good enough job of testing people for HIV. So there were people that were diagnosed at very late stages that have been seeking care, and even though it's standard of care, so they're supposed to have HIV testing, but they were not giving that in hospitals around all over the state. So actually some people actually were diagnosed when it was too late because of that.
There's also, I mean, just to talk about that issue a little bit more, it's become almost an ethical issue at this point in time. Most providers often hesitate on automatically just getting a full-on STD, STI panel, because what if they do come back diagnosed with syphilis, and it's the tertiary syphilis, so it's affected your brain already, or you have HIV, like that's actually life-altering. And so it's become almost an ethical question posed to physicians. Am I going to just gunshot everything, order every panel, and then finally talk to the patient and ask, present them with the results, or am I going to consult the patient and ask them, is this something you want? And is it something that's going to, whether the results come back, is it going to be life-altering? And these are the resources we have available. I think that's an important discussion that it's not heard about all that often. But also just to talk about your previous topic on like, if you build the infrastructure, the people will come. And I think that's very true as of recently with regards to the IHS systems back on Navajo country. A lot of the IHS facilities, whether they're 638 or IHS, have done a great job of integrating what they call traditional practitioners into the hospital systems. And so now you'll see the hospital, and then separately you'll see Hogan, you'll see sweat lodges, and it's really it's a cool blending of cultures. And a lot of even the behavioral health inpatients now can participate in Sweat Lodge. They can go and participate in ceremony or request for ceremony if that's what they want to seek, and it's a good treatment modality when you're in the hospital.
And I think it's systematic too, because some insurance providers and some others have provided a traditional healing benefit as well, where they'll actually assist with some of the expenses related to traditional healing as well.
I'm going to build upon Theresa's comment with regards to the historical mistrust of healthcare. There's also a historical mistrust of research within tribal communities. As a Native researcher, I have to deal with this as I go into tribal communities. Just because I'm Native and just because I'm from a different tribal community doesn't mean I'm readily accepted. There is a huge mistrust of research in these communities. With the Apache community that I have been working with, actually it's been for 10 years now, when I initially went to the tribal council to talk about a research study, a National Institutes of Health funded study by the National Institutes of Drug Abuse, the comments I got were, we already know we have 10 fingers, 10 toes. What other kind of research do you need? So they were used to different types of research, and because of the mistrust and misuse of research, those are long memories and stories. So as a newer Native researcher, again, I had to be reflexive, and that I didn't expect. The treatment I got, and the same treatment I get with my own tribe. And I think it's because I'm Native, they hold you at a different standard. You need to be more responsible, and you know the do's and don'ts. And I had to reflect on it, and I thought, well, they don't know me from anybody. I may be Native, but they should question everyone, irregardless of whether they're Native or not. And I'm really thankful that they did question rather than blindly accept a researcher to come in and do research. So everyone should be questioned. Doesn't matter whether you're from that community or not. So Stigma, that's been the example of, and their concern is, what are you gonna find with your research study? With research in tribal communities, there are some communities that have their own institutional review boards. And the Apache don't have their own, and they rely on a different institutional review board. So their concerns are, if you're going to do research, what are the benefits to us? Don't just tell us what we're lacking or how bad our health is or what we're doing wrong. How can you help us? That's been one of the upfront, when I submit to the Navajo Nation IRB or to the IRBs, they want to know, what is the benefit of this research? Tell us, tell the communities. Don't tell us what we're lacking. We've heard it again and again. We've been stigmatized.
I also just wanted to add too that on this topic of stigma and talking a little bit about Lorenda's work as a researcher and my own too, I think there's topics that make sense for us to address in this academic kind of system, the world that we're in right now. And there's topics that are best left to the tribal communities, I think. And stigma is probably, various stigmas are things that I think that the community has a lot of infrastructure for. They have a lot of expertise around these topics already. There's indigenous knowledge that has been existing for centuries. So the communities have their own systems and their own ways of dealing with challenging topics and sensitive issues like HIV, like even the patriarchy as well. And that there's places where, as academics and as Native researchers, where we kind of have to really toe that line and make those decisions for ourselves as to whether or not it's appropriate for us to talk about those issues in this forum. And I think, those are things that we have to deal with every day. And I think just honoring and respecting that Indigenous communities are not victims, they're survivors. And I think that allowing the tribes to really take and exercise that sovereignty and determine for themselves what is appropriate to discuss in a public forum is something that is that I really hold dearly, is a responsibility that I think is for all of us as Native providers, physicians, and educators too. Is that there's things that I think we should leave to the tribes to talk about amongst themselves, and when they're ready, they'll ask for our help. And when they are, I think we're here and we're ready to help.
Were you going to mention something, Johnny?
Oh, just that concept of people asking for help when it's ready is basically how we started working in the communities that we work in. And we work largely around environmental exposures, and I think that that's another area that it kind of touches on everything that we've talked about, because what we find is that the communities know very well when they're exposed to something that they don't think is doing them any good. And there's a real lack of training anywhere in this country on environmental exposures and resultant health outcomes. And that really gets exacerbated when you start getting into very rural communities where providers are limited to begin with, or don't stay very long and rotate through very quickly. But the Institute of Medicine has said for the last 30 years that that's one of the biggest deficits in our healthcare system in the US across the board. And so when you magnify that into tribal communities, and we look at communities coming to us and saying, we're exposed to abandoned uranium mines, that's the particular area that we work in, and there's 4,000 of them in the western, more than 4,000 in the western US. There's 160,000 abandoned hard rock mines in the western US. 40% of the surface water in the western US is contaminated by the runoff from those mines. And communities are really aware of that. They know that completely. And they really believe that that is part of any health effects that they're seeing changes in over time. And yet they go to providers, and that's part of where the distrust of providers comes in our experience, is that providers never ask about their exposures in general, not always, but for the most part, they're never asked about their exposures. And the fact that 35% of people in some of the tribes are drinking from unregulated water sources, and yet their source of drinking water frequently isn't asked. Obvious source of either infection, infectious agents, or also the contamination from the abandoned mines. And it creates more of a distrust between the indigenous and community understanding of what's happening and their faith in providers to be able to diagnose that and treat it. And so I think that's another area where we get definite culture clashes. And the research is not just it's not just a distrust of research, and that thing of how is it going to be used to benefit can only benefit if we can also get that across to providers. And providers want to help, and often when you find an environmental disease, we can't tell people what can make it better. We can try and find interventions that work, but I think it makes providers very uncomfortable when we come back and say, yeah, this person has a really serious exposure to 5 heavy metals, and they say, what do we do to fix it? And we don't know what you do to fix it other than clean up the mines and remove the source of exposure. And so I think that puts everybody in a really uncomfortable position.
Okay, we have about 12 minutes left for you guys to speak. So I want each of you to spend a little bit of time focused on a particular question. So given the expertise of everybody on the panel, I'd like each of you to speak about your own work and how it reflects Native American community, health communication needs, and how this work might inform other communities as well.
I can go really quickly. I'm not a Native American researcher, and this is one of the reasons that I never seek out Native American communities. So in my research, whether it's the HIV, where I did needs assessment for the Department of Health across the state, or here at the Cancer Center, or with early childhood development. I did the study either in the whole state or in specific communities that were geographic communities. And then if people were in the community and wanted to participate and they were Native American, then they participated. But I didn't particularly went out for the same reason that you mentioned, that I just didn't feel it was ethical. So I don't feel my research necessarily my research has implication to very diverse local community, both geographically and ethnically.
So it was health communication approaches?
Yeah, if you can talk about how it reflects community health and communication needs, and how it might work to inform other communities as well outside the Native American communities.
So I'll speak in terms of how the work I've done with tribal communities on research, how the means of communicating that we've used. Nathania touched on, we're storytellers, and I think it was mentioned Theresa mentioned digital stories. So that's been one of the means we've used to share the work they've been doing. So the tribal communities I've worked with, we, using a community-based approach, we developed tribal research teams. We call them tribal research teams because we develop their knowledge and expertise in how to do research. So we've been able to share their story and their journey in this research process through digital stories. We've recently just developed with the three main communities I mentioned, an Apache, Navajo, and a Pueblo version of their own digital stories. And we did one here for our team at UNM because we're our own community as well. So digital stories has been an important means of sharing our story. The other means of communicating and sharing with the community, one of the community has its own newsletter. So they write up a little article about the work that we're doing, the research study itself. And we'll also produce annually with our communities infographics. So traditionally, when you went to the doctor's office, you had a pamphlet you'd read about whatever, a disease or a health promotion event. We don't have time for that anymore. So we've gone to infographics, one page, packed of information, colorful, bright. You can glance at it as you're walking by. We've developed infographics for them to share about the research process. And then we also just come together and we meet and have a lot of face-to-face meetings, because email doesn't always work, and telephone calls, you can't catch anybody anymore, and cell reception may not be so good if they're out in their own communities. So those have been ways that have been effective for us and our team.
When you mentioned digital storytelling, where is this being disseminated?
Good question. So a number of different places. We have a website here here at UNM, the Center for Participatory Research. That was part of my introduction. We have those digital stories on our website, and the communities have their own. So they actually have it on a jump drive. So if they ever have to go to a meeting, I have to go present to the health board, I have to present to the council, they have their story. They can talk about the work that's being done, and it's not, and it's visual, and it's not something that's a report or they get lost. And so it's quite handy. They have it on a little jump.
And to add to digital storytelling, I partner with the Healthy Native Communities Partnership, which is out of Shiprock, New Mexico, and they have hundreds of digital stories. And we also, with the Indian Health Service, Health Promotion, Disease Prevention national website, we have a number of digital stories on there. From the Albuquerque area, I've collected about 120 stories.
Oh, wow.
So.
And how do you go about getting them?
They're on the website. You can
No, I mean, how
view
do
'em.
you find the people
Oh.
that you want to work with to
Oh, okay.
capture the stories?
I'm one of the trainers on
Okay.
digital storytelling, and we invite communities who want to share their story or get their voice out there. And like I mentioned, working with the Healthy Native Communities Partnership, so it's just really putting it out there, and we also get requests as well.
I think the most obvious answer for me is obviously to become a medical doctor, but I eventually want to return home. I think that's something that has always been my biggest goal. But I want to do health policy eventually, and do health policy work because I think legislation is malleable, and it's something that we can hold ourselves it's something we can hold ourselves attestable to, but something we can also change if we don't see the improvements we want. But also I think at the very end of the day, being in this position and it being a minority student is something that's ultimately dominated by by a different culture, is a unique position to be in because you're living this experience that was not meant for you and that wasn't made for you. But it's a cool position to be in because you can motivate people, not only like yourself, but from different walks of life who share similar experiences, to have a chance at becoming a physician, have a chance at making a difference in their community, whether it be through law or other modalities. And I think being a medical student is not only having a role as being a person's healthcare provider, but listening to them and seeing them living in their social contexts. And I think that's really important.
Well, in my work, I'm a health planner, community and regional planner. So I'm not a clinician. I don't have a health background, but I think communication is a huge part of my profession as a planner, because storytelling and collaboration and communal engagement and also decision making together is at the core of my profession as a planner. And so I feel like I do communication work and also planning every single day, even in making decisions with my team, to as big as providing capacity building opportunities for tribes and off-reservation communities. I think communicating knowledge from one person to another is such an incredible process to witness and to be a part of. Adults learn so differently than students do, and so it's really important to know how to communicate. Even as simple as hand gestures. I know I talk with my hands a lot, but those are things that you pick up along the way when you start to really look at how people communicate with each other and how they get their points across. It's really an incredible process, and I think I'm really grateful to be here at the university where they support an entity like our center, which is the Center for Native American Health, and also all the great centers represented here. Our center, just to summarize, it really focuses on student and workforce development, so retaining Native Americans into the health professions, and then also helping to close that loop by helping prepare tribes to receive those students back after they're finished.
One of the things that we've instituted fairly recently in the last 2 years, I guess, is we have artists who actually work with our program. So we have a Native Artist in Residency program. We currently have a Zuni artist, Mallory Kataki, who's working with us on translation of science. And one of the big goals of that is not only for translation of our science back to communities, but for translating community knowledge and awareness back to our researchers. And that program has been so far we've been really excited about it. We have other artists who help us doing videos to help communicate what we do. But I think that the issue of being able to build that multi-directional communication is really the key to making system change. And so we look at the whole communication process as something that has to involve policymakers, healthcare providers, community members and researchers, and that developing a common language among those four groups is really essential to start making the kinds of changes that will long-term benefit communities and change the way research and healthcare happen.
I work at the Indian Health Service, Albuquerque area, and we service 27 tribal areas in New Mexico, 1 in Texas, and 2 in Colorado. So we call them the 27 areas. And communication with all our different areas that we serve is crucial, of course. And we have quarterly meetings with our tribal leaders. We also communicate through email, put things on the website, which becomes outdated really quickly. But I think what is really key with our communities is that person-to-person contact, really making time to call them or go talk to them in person and invite them to one of your health events or whatever it may be. And so having that open dialogue and communication. And I wanted to point out one of our former governors that is here tonight from Tesuque Pueblo, Governor Trujillo, or Vigil. Vigil. So he came out and he got communication through email today to be here, so thank you for being here. And so just, people getting to know you and trust you through the years. And also being at the University of New Mexico at the Prevention Research Center before I went to IHS, working in research was, really key, and getting to know the people out in the communities as well. So communication is definitely very important, and it takes years sometimes to build that trust with a lot of all our different communities. And it takes time, and when you say you're going to be there, you be there, no matter if it's 10 o'clock at night or whatever it may be. It's just being dependable and reliable, and making sure that you build those relationships.
Okay, and with that, we're going to wrap up this discussion and open it up to questions from the audience. So if you have a question, if you could just raise your hand and wait for us to get to you, then that would be really appreciated. So we have about 25 minutes to take some questions. And I'm sure they would love to answer them. If you have a question, that means somebody else does too. So there's no questions. I find that hard to believe. Okay, yes, go ahead. Thank you.
Not necessarily a question,
Okay.
but being in this environment and working in the system, like a critical component is communication. And a lot of people have this assumption, to where, again, you have Native American researchers now, to where opportunity to be, in layman's terms, some of the things we're doing in research. Recently, I just attended last week, Zero Suicide Academy. The health system, how complex it is, and it's for everybody. Just like here, you guys as students, you come to the university assuming that everything's going to run you through the system nice and easy like, but there's always a flaw. And when you explain that situation to people, how do we improve it? It's again building relationships. How do we enhance this process? Just yesterday, I attended the tribal consultation meeting with the Social Security Administration. With new federal policy, how does that affect all of us? Just an ID with the motor vehicle department. Now they're requiring all sorts of information in order to just get that ID. And that's where, again, now with the infrastructure of technology, put it in the website. Apparently I had to stop the guy because he was going 110. I said, wait a minute. You know, that's the process you gotta understand. That you articulate what you're trying to say. And like tonight, the challenges as a tribal leader, I saw the insights. Everything's moving so rapidly. You know, dealing with the state legislature, dealing with the United States Congress, and your own people, to where, what is the major perspective to where I bring it back home? Our way of life. What did we do way back when? And in my community, they have what they call a community town crier. And back then, we were all needed very closely to where any kind of community function was happening, this individual would inform the community. And now we've moved out of our central location to where we're out. And in my academics and business administration, what's my way of communicating? Technology, right? Like we were saying, you got to chat on Twitter. To where, how do we bring that infrastructure into my community? Today, I'm proud to say, I have technology in my small community school. To where next month, they're going to be showcased in the Office of Juvenile Justice. Again, development of the Youth Coalition. Same perspective in terms of prevention. They did the YRS data portal that you guys do in high school. They did it in our community. And they brought that information to us as leaders as well as to the community. Wow, it woke everybody up. To where, again, the digital stories, some very heart-touching. But those are the realities out there. And how do we look at this institution? I have some young men and women that attend this institution. To where, how do we build that network? You know, to get healthcare providers in our community. We start something, we're going good, then the administration changes. For 8 years, we've worked effectively with President Obama as leaders. Now we're going backwards. To where one of the questions that was raised was, how do you define quality health? I asked this to the Albuquerque area IHS leadership. To this day, I haven't had an answer. To where, again, you look at the health disparities. That's what I saw as a leader. I want to change that paradigm in my community where we say we're a healthy community. And that's where my engagement that happened here over the course of time, the data research. You know, what are the health impacts to the medication we take? What are the impacts to the mental stability of our people? And for me, advocating for behavioral health statewide, not looking at color, but for the need of our people. When Medicaid expansion happened, we were out there hustling, getting people enrolled. We saw the volume increase, and then here's the state budget shortfall. Took it all the way to who? The people that were needing that service. Rather disappointing. So even yesterday, a lawmaker passing law, if you guys want to go further, House Bill 99 tells why we have to do the protection on our identification. And one of the legislature even went, got denied. And those are the stories you see. You know, to where every one of you share, especially you from the Native communities. I come from a community that is very restrictive on our way of life because we see it as a mistrust. And that's where we talk about historical trauma. It's happened to everybody. And when I saw a video known as the Wild Variety Movement, the grandmas, grandpas, dads, moms, aunties, uncles that experienced, I had conversation with my elders. I don't want to talk about it. Well, hopefully it would change. But it's not changing because we're living that same cycle. And that's where more education, more experiences, to where, how do we build this relationship of humanity working together? And as a leader, I'm involved because I'm looking at my community. Now I have 9 grandkids. I see it in their eyes and say, what's going to be your future? So I, as a leader, is preparing for their future. And like I see the future of these young men and women, to be those professionals that will sit there. You know, and that's where, again, how do we support society? And it's very challenging. So with that, I applaud all of you. You know, and that's where, again, working with the Native American Science Center, building relationships, to understand to an elder that may have not even spoken English, to translate it to them in my native language, to make them understand. Well, some of our elders don't trust because they saw that experience. So that's a barrier for them. So I just wanted to share that. You know.
Janine, you want to respond to that?
There's a question back there.
Oh, okay. I didn't see that. Caitlin will come to you.
Hi. Oh, okay, there you go. Yat she Shana Nelson Yinishe, Nakarine Nishle, Honagani Bashishin, Tatnazani Shiche, Do Tobahan Dashinale. I am a research assistant right now I just drove all the way from Window Rock actually for Defiance. I'm a research assistant with the Department of Health Navajo Food Access Navigation Program. And we are a demonstration project through the Healthy Hunger Free Kids Act from the Obama administration. And what we're trying to do is advocating for hungry kids. Any school-age children less than 8 or younger than 18 years old should be able to get meals at school, breakfast, lunch, dinner, snack. I'm newly appointed to this position. I have been acquired to 3 communities. I just got another one, 4 communities. This project is initialed for 2 years, so it's a short time span. We're already a year and a half in. We have about 10 more months left. And as a new person, this is my first time working within the nation, the Navajo Nation, working with tribal members. So I have, this is my first time working using my degree for something. So I'm hearing a lot of interesting things while training. I'm learning a lot of things from the community members, from the people that work within the nation. And right now I'm just gearing up to doing as much research about the communities and about the programs before I go out into the communities. Just the other day I went into a separate community from my own, and from that I experienced a lot of communication, like Theresa had mentioned, just going person to person and meeting with the school, the chapter house, and the senior center was very interesting. But at the same time, it's also very nerve-wracking. As a young student coming out into the field now, I've learned all the infographics, the Prezi, the high glossy flyers to attract people. But the communities that are out there and the people that are in these communities, the ones that we're talking to, aren't young, modern. They don't, infographics is too much. They just like a simple agenda, a simple flyer. And to me, it's like, you could do something better. But then, to grandma and grandpa, it's like, it's easy for them. And, a simple agenda, they could go 3 hours on, 2 points on an agenda. So as a young person, I have all these like new creative things, but at the same time, in a short amount of time span, this job has had a lot of turnover. So they have seen a lot of different research assistants come in. They were tribal members as well, but they've only been there for a short amount of time or longer time, and something else grabbed their attention. But I just want to know, how is it that I can prepare myself to go into these communities that have historical trauma that already, even from just other members in the program or in the community, are telling me that chapter house has a CSC that's like this, or the food director over there is a real problem, or the teachers want the program but the food director doesn't. And so I don't know how to communicate with this older generation, because I've been taught to be able to communicate with the younger generation. Prevention. And right now there's still older people in that generation. And I have a language barrier. I'm not fluent in Navajo, so I'm already expecting that. So I'm practicing my introduction. So I guess, that's my question, is how do young people, when they're going to these tribal communities, how is it that they can address or communicate with the older population when we were taught to be really extravagant? And they don't need that. Yeah, they don't understand it. And then sometimes they just close up, and then it's like, okay, what do I do? And you try to go back to your textbook, and you're just like, you don't have your textbook with you. So remember that, students. You can't carry
Learned on the job.
You can't carry your textbook with you.
That it's on the job training.
Right.
So, hi Shauna, I know Shauna, she's a graduate. So I think that's one of the things lacking here. Here, when I say here, I mean UNM, the institution. The academy doesn't allow us to do that. Shauna is an example of other students I've heard back who try to go back to their communities and try to do work, but they don't have that knowledge that that the academy doesn't train them to be able to go back to their communities. We train you on other things. I've heard Shauna's type of story before. So I thought, okay, I'm going to create a class. I'm going to focus on Native health. I create this class. I do a syllabus. I put it on the schedule. How many students register? One drops. Back down. It doesn't go. I just can't get the students to the class. It's that I've attempted it. I've tried it, and I just can't. I can't get the enrollment. So I can run the class here at the academy to talk about those issues, to talk about the way things are done, where they're going to go back into. So that hasn't happened here. We haven't had that critical mass to be able to run those classes. So guess what I'm doing this semester? I have a problems class. I have independent study, and I have 5 young Native women in that class. So I'm experimenting. And as faculty here in the academy, I don't run problems class, don't run independent studies class. You don't get paid for that. You're taking time, I'm taking my own time to run those classes. I'm taking time away from, it's perceived, I'm taking time away from other things I should be doing. But that's what it's going to have to take right now to be able to be responsive, to be able to think of ways outside of the box to get that, to have those types of courses to address those kinds of issues. And a lot of it, again, is cultural sensitivity. If you weren't raised in it, I was raised with silence is okay. Some people are uncomfortable with silence. I'm fine with it. But if you weren't raised with it, oh my gosh, that's the hardest thing for some people to deal with. Like, oh gosh, what's wrong with me? Nobody's talking. What did I do wrong? What did I wear wrong? It's not that. It's not you. It's appropriate. So I see a hand there. So unfortunately, Shauna graduated before I had my independent class, and it's not happening. But we have to think of ways how to better prepare individuals
And
going out.
unfortunately, I think this will be our last question. So I'm going to let you go on, but then afterwards, you'll obviously be able
Can
to
I
talk
respond
to
to
people afterwards.
Shauna's question?
Yeah,
real
absolutely.
quickly? I just wanted to also add to what Lorenda said too. I think as somebody who went through the same process myself of going to school and then going to the community, I think understanding and respecting that the value systems are different between the academic system or the Western culture and Native American culture is, I think, key. Western culture values youth. We value energy. We value, all those innovative qualities of youth. But in Native culture, we value experience, and we value elderhood, and we value long, deep thoughts, silence, those thinking, those long processes. And I think as you get experience with those silence or with some of the values that Lorenda talked about, you'll find a happy medium in the center. But I think exercising humility and understanding that you come with a humbleness about you, I think is really going to take you a long distance. And that doesn't just go for you as a research assistant, that goes for everybody who's BAMD students who will be going back to places like that. That humility really is, I think, a really a key characteristic to have. And I think if you exercise humility, that goes beyond the competence, that goes beyond the sensitivity, is knowing what you don't know, that you don't know everything, and then being okay with it. And allowing yourself to learn on the fly.
And again, I mentioned being reflexive, you reflecting on that experience and learn from it. Don't get mad about it. Don't let it be your stumbling block. Learn from it and just reflect on it and accept that, oh good, like we said on the job training, you've got to experience it. I'm not able to tell you what every situation will be. You're going to have to be out there and you've got to learn and then just try and take that learning and move forward.
I really just wanted to make a comment. I work over in the Department of Biology in the Initiative for Maximizing Student Development, and it's a STEM program. We work with students who are undergraduates who want to do research. And what I've noticed over the last 3 years is there is an increase in the number of students who want to be able to go back home and do research. And so the question from you was very timely because I was trying to figure out how to ask that question, but you did a beautiful job, so thank you. And I'm going to contact you because I have questions for you, because I want to be able to direct our students to you. Because I think eventually there'll be a critical mass and you'll be able to do the class. So that's all I wanted to say.
Thank you. Did any of you want to say anything as we wrap up? Sure.
Is it on now? Okay. Just to comment one last thing on what Shauna had mentioned, I know I'm very fortunate that I speak Navajo and I'm relatively fluent, but just because of my age, a lot of people back home will constantly continue to ask me questions at the very beginning of our patient encounters and question how far I can go in this conversation, just purely speaking in Navajo. And then once they finally deem me fit, they'll let down that barrier. And it's an unfortunate reality that most youth face when going back to their respective communities. Is that one, they're going to be dismissed if they're not familiar, and that's not a reflection of them. It's a bigger problem. But after that, I think it's important to also incorporate things that we grew up doing, like laughing and being funny is such an important thing in Native communities. What's really unique about the medical school here is that they send you to underserved communities back in New Mexico, and I decided to go home and spend an entire summer doing family practice. And most of these patients were like people from what I call the boonies, and I grew up in the boonies. But grandmothers who were not taking their hypertension medications, were not taking their statins, and they, first of all, didn't have an understanding what these medications were doing or how they worked and what they were trying to do. And they didn't even have an understanding of what hypertension was. And taking that time to fundamentally explain first the pathology and the mechanisms that these drugs, how they were doing is like fundamental to their just understanding, but also relating it to things they know. And like growing up, I was very fortunate also to grow up around sheep, and we butchered almost like every other weekend. And relating like, oh, well, your heart, and just relating it to sheep's anatomy, and like, this is what this is doing, and this is how this is targeting it. But also using humor, like I can remember this one instance where this grandpa, like, refused to take his hypertension medication, and like constantly came in with blood pressures that were very alarming. And then we just started talking and like having a conversation because it was coming closer to winter, and our winter dances start in October. And I started joking with him like, hey, if I dance and you dance behind me, then you'll take your medication. And then like 3 weeks later, he came in and his medication, like he was compliant or adherent to his like treatment plan, and it was the blood pressure was coming down. And it's just, it's important to incorporate things that are familiar to your patients or to whatever population you're working with.
All right, well, we are out of time for this evening. I thank you all very much for coming out to talk with us about this really important topic. I also want to thank our co-sponsors, the University of New Mexico's Department of Communication and Journalism, and the graduate student group, ComGrads. Kim Osterman is here in the audience, and she was great in helping us secure space and getting things established for tonight. And also a special thank you to Tamar as well. She was very instrumental in getting all of this off the ground for us here, and I appreciate all of your help. So again, thank you all for coming out tonight, and I hope your conversations about health and culture and the role of communication don't end here. So thank you so much.